Hi, welcome to our next topic of discussion, that is periodontal plastics. Orthodontic paralleling of roots. For example, imagine a scenario. This is your bone, these are your incisors, and these are the direction of the roots. If you see, the roots are diverging. Because of this, your contact point, which was supposed to be at this position, has moved coronally. Because the contact point has moved coronally, this distance from the crest to the contact point has increased, and if this distance becomes more than 5 millimeters, or you can say if it becomes rather more than 6 millimeters, what we get is absence of papilla. So what we can do is we can orthodontically upright the roots. If we upright the roots, what will happen is the contact point will move down because of the uprighting of the roots. And what we get is squeezing of the papilla. There is less space here. This papilla squeezes and it falls. This is the orthodontic non-surgical technique for the correction of the papilla loss. Then we have another technique, that is mesiodistal enamel stripping or orthodontic movement. This technique is specially applicable if you have these conical shaped incisors. Maybe if the roots are parallel, or maybe they are non-parallel. We are not applying the orthodontic therapy here. This is your bony crest and your contact point is here. What you can do is to squeeze the papilla, you can try to shift the contact here. How you can do that? What you can do is you can go in for proximal stripping. You can just strip off this area and you can just strip off this area, and then what you get is this space. And then you can go in with orthodontic correction of this diastema which is created because of stripping. So that is mesiodistal enamel stripping and orthodontic movement of the teeth. So what will happen is your contact will be localized to this point and your papilla will be squeezed in this distance, which is now decreased to less than 5 or equal to 5 millimeters. So that is the orthodontic cum prosthodontic correction. Then you have the gingival prosthesis, that is a prosthodontic. You can just take an artificial gingival prosthesis, or you may go in for restoration of tooth. When we say restoration of tooth, again, contact which is situated more coronally. So what you can do is when you restore the tooth, you can make the contour a little bit more bulgy here, and what will happen is your contact will shift down, squeezing the papilla and thus filling the papilla. So that is the non-surgical technique for the correction of the loss of papilla. Then we come to ridge deficiency. Ridge deficiency classification was given by Seabird in 1983. You have class 1. Class 1 is the loss of buccolingual width. Class 2, it's the loss of apicocornal width. So we have buccolingual, then we have apicocornal, and both the loss together we have class 3. Crown lengthening. Crown lengthening. Why the crown lengthening is indicated? We need it for biologic width violation, we need it for short clinical crowns, gummy smile, and gingival margin discrepancies. So this is an interesting topic, but before we go to the topic, we need to understand what is biologic width. The biologic width concept was given by Gargilo. Again, you have MCQ. And biologic width is defined as junctional epithelium plus connective tissue attachment above the crest of the alveolar bone. So what we need to have is, this is the crest of the alveolar bone and this is your junctional epithelium. Sum of two is your biologic width. And usually it is 0.97 plus 1.07, that is equal to 2.04 millimeters plus minus 30%. And if you place the restoration within 2.4 millimeters, if you violate this biologic width, it results in inflammation. Now if the biologic width is violated, what do? We can go in for surgical crown lengthening, or we may go for surgical extrusion. How do we correct the biologic width violation? We can go in for surgical crown lengthening, wherein we shift the biologic width by surgically. We have other techniques such as orthodontic extrusion, in that we have two types of extrusion. One is slow extrusion with low forces and rapid extrusion. So when we try to extrude the tooth slowly, it brings its attachment apparatus with it. So what happens is, even the gingiva and the bone, they grow with the tooth. And what you can do later is you can go in for surgical correction. Now, why are we doing that? When we had to do the surgery, we could have directly done the surgical crown lengthening. What happens, for example, you have this incisor and you have this incisor. Unfortunately, there is an accident, and what happens is this. Now, in such a scenario wherein you have one tooth intact and one tooth, if you try to do a surgical crown lengthening of this tooth for the biologic correction, you may land up doing correction, but it may result in gingival discrepancy. What do we do to prevent that? We have one way that we extrude this tooth slowly so that it brings with it its attachment apparatus. So what will happen is the new gingival margin would be somewhere here. This is your extruded tooth. And next, then you can go in for surgical crown lengthening this way. So this is your tooth, this is the extruded tooth, and after surgical crown lengthening, you are able to get the equal gingiva from both the sides, and that is why we had been doing the slow extrusion. Second method is rapid orthodontic extrusion. In rapid orthodontic extrusion, what we do is we try to pull out the tooth rapidly so that it does not bring its attachment apparatus with it. Secondly, we can also go in with supracrustal fibrotomy to prevent the eruption of attachment apparatus with it. So we have rapid orthodontic extrusion with supracrustal fibrotomy. So what happens is gingiva doesn't move, only the tooth moves. Thus the gingival discrepancy is not a result. So that was about biologic width. With this, we finish our mucogingival surgery. Next, we'll be talking about furcations.